This chapter is dealing with the part of the central nervous system that we call the brain. And also we're going to be looking at the cranial nerves, the 12 pair of cranial nerves that actually come off of the brain. So let's go ahead and get started. When we think about the human brain, obviously I think we're on just the tip of the iceberg and as far as our understanding of everything that goes on in the central nervous system, including the brain. And we also understand, though, that activity from the brain is what we consider to be clinically alive or dead. So with 24 hours of no brainwave activity is actually the clinical definition of death. And that's just something to think about as well. So let's jump right into this and get going. When we look at the brain and the anatomy of the brain and the structures associated with the hemispheres of the brain, we are going to be looking at the different parts and making sure that we know the specific functions to each part. And again, the reason for that we would know that is that if anything is injured or damaged due to trauma or pathologies, then we again know what's associated with what functions are associated with that particular site. So a lateral view of the brain, this is a lateral aspect that we are looking at, this being the front, so eyes, where you see my mouse, that mouse is, these would be the eyes here, nose, mouth. So this is the front, this is the frontal lobe of the brain, and this is the back part of the brain. We see that there are a couple of terms that are associated with this. Rostral is toward the forehead or nose. Caudal means toward the tail or back. So that's what these terms are referring to. When we look at this, we see that most of the brain is made up of these lobes that are all of the lobes are part of the cerebrum. Inferior on the caudal side or posterior side, we see inferior to the cerebrum, there is a part of the brain called the cerebellum. Now on this illustration, they have it illustrated as looking slightly different from the lobes of the brain, and it does look slightly different from the lobes of the brain, and it's significantly smaller. But we know that 50% or more of the neurons that we think of as those all-important nerve cells that are actually detecting, interpreting, sending signals to other cells are actually found in the cerebellum. So we want to make sure we understand that the cerebrum is composed, and you'll be labeling this in your drawing, the cerebrum is composed of all of the lobes, the frontal, the parietal, the occipital, and the temporal lobes. The cerebellum is inferior to that occipital lobe. The brain stem is composed of the pons and the medulla. We'll look at that, take a look at those. And this is just some of the terminology associated with this. When you hear the terms gyrus and sulcus, gyri is plural for gyrus. Sulci or sulcus, those are also singular and plural. The sulcus are actually these indentions or almost look like divots or ditches, and the raised areas are the gyri or gyrus is a raised area. That is what those two terms are related to. So the central sulcus, which you can see here, the central fold, the central sulcus actually divides the frontal lobe. So the frontal lobe is huge. The frontal lobe is huge from the parietal lobe. And they have those two lobes have very different functions. So though the cerebrum looks like the largest volume, we do understand that the cerebellum, this area, actually contains as many as half of the neurons. So very important, and only until recently has more been understood about the function of the cerebellum. We'll see that in just a minute. When you've ever heard of the brain stem, which includes the pons and the medulla is here and the pons here. The brain stem is the area that we think of that controls so many things from consciousness to cardiac function and respiratory function. So whenever you've heard that there's been injury to the brainstem, never is that a good thing to hear about, because your autonomic nervous system that's controlling your breathing, your cardiac function, and even your consciousness is controlled in this particular area. When we look at a superior view of the brain, so we're looking at from the top above, we're looking at the superior view. The frontal lobe, you can see here, and it is a large area from the central sulcus to the front. The frontal lobe, we have these two hemispheres, so the right frontal lobe and then the left frontal lobe. There is, and I told you about the gyri and the sulci. The longitudinal fissure, a fissure is really a separation or fold. This fissure is separating the two different hemispheres. There is a structure that connects them. Now we can't see the structure on this view, but we'll be able to see it in a second when we look at the MidSagittal section. This very thick nerve bundle is called the Corpus Callosum. And let's go ahead and look at a MidSagittal section. So if I were to take a knife, and dissect the two hemispheres and look at a MidSagittal section, I would have to that knife wouldn't hit anything until it got here to this thick fold of nerve bundles called the Corpus Callosum, and then I could cut through that. So this is a MidSagittal section where you can really see that Corpus Callosum that is kind of the highway between the two hemispheres, the right and the left hemispheres. So going back again, if I took a blade and went down in this fold between the two hemispheres, I wouldn't hit anything until I got to the Corpus Callosum, and then that Corpus Callosum I would cut to separate the two hemispheres. Let's see if I want to. So this is okay. We can do it. We can look at this from here, and actually on a human brain that has been cut for you in a dissection, you can actually see this Corpus Callosum. Again, connecting the right and the left hemispheres of the cerebrum, all of the lobes. So an interesting just FYI for you is that the Corpus Callosum on women is actually thicker than the Corpus Callosum on men. What that means, we don't know, but there is a difference between the genders. Now I'm going to go back to the illustration just because it's a little bit maybe easier to make out. And I'm going to already talk to you about some of the different functions from the frontal, the parietal, the occipital, and the temporal lobes. The temporal lobe of this right hemisphere, you can only see the medial aspect of it. I would have to go back to a full view to see the actual lateral view to see all of the temporal lobe. So from this view, from a MidSagittal view, I can only see the medial aspect of the temporal lobe at this point. But let's go ahead. I think it would be actually from this slide, it would be okay to start our introduction of the functions from these different lobes. The frontal lobe, which again is all the way from the central sulcus, the central fold, all the way to here is the frontal lobe. The frontal lobe is where personality, judgment, planning, all of those activities come from your frontal lobe. You have maybe heard of the pre-cortex region of the frontal lobe. When this is injured is when someone's actual personality changes, and it's because this is where we know all of the planning, all of your decisions about how you're going to act on something is coming from this frontal lobe. Also, what comes from this frontal lobe, and it happens right here. Now we can only see the medial aspect of the right hemisphere here, but we understand that if we were to go back to the lateral, it would actually be this entire, just right here on this frontal lobe. we know that what is happening here is planned movement, so voluntary skeletal movement when you are writing notes, when you decide to walk across a room, when you decide to pick up a coffee cup. Anything that's a voluntary movement is coming from just anterior to, in front of the central sulcus, which is part of the frontal lobe. So planned movements and personality, all coming from the frontal lobe of the brain. The parietal lobe, which we know includes, that starts here, post central sulcus, behind the central sulcus, and all the way down to this area where my mouse is. The parietal lobes of the right and the left hemispheres are going to be sensory. So if something is crawling on a little tick is crawling on your leg, I don't know, I always think of ticks, but anyway, someone kisses you on the cheek, sensory. So sensory is going to be in the parietal lobe. You may sense something is hot that you're touching, so a message gets sent to this frontal motor lobe that sends a signal to tell you to move your hand away because, you know, it's hot or it's cold or whatever it is. You have planned movement because you sensed it. So sensory is parietal, frontal is planned movement and personality. Occipital, this occipital lobe, which from this medial aspect of a mid-sagittal section, we can see here looks like a wedge here. This is in the posterior part of the brain. This is where your visual centers are. So you might be thinking, and that's back here, you might be thinking that you're seeing with your eyes, but you are not. Your eyes are detecting and sending electrical impulses back to the occipital lobe of your brain where you are processing vision. And from that process of vision, information gets sent to other areas of the brain, especially this temporal lobe. And again, you're only seeing a little part of the temporal lobe here, but I could go back to this and you see this is the temporal lobe, all of this that my mouse is on. This is where memory and even emotions, hearing, some parts of your sense of smell, these are in the temporal region. So you will visually process in the occipital lobe, send signals to the temporal lobe so that you can put, as far as memory, you can put names and labels and even emotions to that, what you are seeing, that visual image that you are seeing, and then how you process that memory, how you process that, and you're going to think about it, is going to be in this cortex of the frontal lobe. So all the areas of the cerebrum are being engaged for you to be processing all of these different senses and all of these different thoughts. So this is why you can have injury to the occipital lobe, the back of your head, and be completely blind. This is why if there's injury in the temporal lobe, you can lose sense of smell. You can lose the ability to, for your emotions and memory. They can all be affected if there's damage in the temporal lobe. There's an area here in the frontal part of the brain called the Broca's area, and an area back here in the sensory called the Wernicke's. The Wernicke's and Broca's, and we'll have this in the notes in a second, that are part of language. So you can have injury to either the Wernicke's or the Broca's area and have problems with communicating. And we're going to take a look at that. But this is again why you would want to learn these specific functions for these specific areas. So for example, if you had a stroke, and a stroke would mean that there was bleeding that was putting pressure and damaging certain areas of the brain, depending on where the stroke happened and what area of the brain was damaged, you would absolutely understand why the patient is exhibiting the signs and symptoms that they are due to that particular damage. So did a lot of the lecture from just these couple of slides, but there are going to be other PowerPoint slides that we will reiterate some of this information. Again, the brain stem that we said included the medulla and the pons. This is the area where cardiac and respiratory functions, as well as many other things, actually go on with the brain. So this is the brain stem. The midbrain is here. The thalamus is said to be the gateway for the cerebrum, and you can see as information will come up through the spinal cord, move through this area, through the midbrain to the thalamus. The thalamus is this region here. This thalamus is going to end up sending information where it needs to go. It sort of is the gateway or the gatekeeper to the cerebrum. Below the thalamus is a major organ, really, of the endocrine system called the hypothalamus. The hypothalamus. This hypothalamus is now considered to be kind of the seat of your universe, the seat or the throne of your universe. The reason that it is considered that is because this is controlling a gland called the pituitary gland. And if you look, just beneath the hypothalamus, there is this stalk of tissue that connects it to the pituitary gland. The pituitary gland secretes hormones that are going to have widespread effect throughout your body. These hormones are going to turn on or turn off the thyroid gland, the gonads, ovaries, and testes. It's going to have far-reaching effects, these hormones. And the pituitary is only carrying out those functions because the hypothalamus is telling it to. If you have ever felt thirsty, that sensation came from the hypothalamus. If you ever felt like you wanted to have sex, that sensation originated from the hypothalamus, sent a signal to the pituitary, which then sent signals to other areas of the body. Temperature control, almost anything that you can think of as a major drive for survival is coming from the hypothalamus first, sending signals to the pituitary, which then sends signals on to widespread areas of the body. So this is why it used to be that we thought the pituitary gland, and I think this kind of moved a little bit, it used to be thought that we thought the pituitary gland was the center of our universe, but now we realize that it's being completely, I had moved that, it is completely controlled by the hypothalamus. The pituitary is controlled by the hypothalamus. Behind, to the back, toward the caudal or the back side of the brain, there is another little gland called the pineal gland or pineal gland. Either pronunciation has been accepted. I want to make sure I get this. Well, now I don't know where it was. Let's see. I want to make sure I get this back to there it is. So pituitary is here. The pineal gland is here. This gland is considered to be our third eye. The reason, and you can't see it from this diagram, but you'll see it from another in a second, is that this gland is just in between where the optic nerve crosses. So it is considered to be kind of the third eye. As light waves that we perceive with our eyes, as light waves stimulate those receptors, and that electricity is sent through the optic nerves as they cross, this pineal gland is also affected. This gland is going to end up secreting serotonin by day, daylight, and that serotonin gets converted to melatonin by evening, which helps us to rest, to sleep, to, slow down, rest. Rest is a vital part of our health. Sleep is a vital part of our well-being. And that 24-hour circadian rhythm that we're on of secreting serotonin and melatonin is coming from this gland. This gland is stimulated by sunlight stimulation, and this is why it's considered the third eye. So I've talked a lot about the brain anatomy, some of the major structures just from this slide, the major lobes of the cerebrum. I haven't mentioned the cerebellum, but we will have a slide based on that, and we'll understand that this plays a major role in all of those functions. It's also connected to all of those functions as well. And we'll just keep going here and looking at the brain. Again, looking at dissections of a human brain, these are very nice. Your revealed human anatomy and physiology reveal that you have access to the cadaver is actually a better dissection than even this, because we know when we look at these types of dissections, they've been exposed to preservatives, which can change the tissues somewhat. But those cadavers that you have on that anatomy and physiology revealed are very recent, fresh specimens that have not been exposed to those types of chemicals yet, so it's even a better way of looking at that. I've explained to you that gray matter is actually where the somas, or the neuron cell bodies, are. Dendrites and synapses, that's the gray matter. The white matter is actually the axons that have been wrapped with myelin. So this is just a repeat of what we had done in our introduction. I hope that kind of makes sense. And looking at embryonic development, you can see that very early on, the entire central nervous system is open and exposed. And it's only after, so many weeks of development that it ends up being closed in, and it takes a while for that to happen. At fully developed, it has now turned into what we associate with a fully developed brain and spinal cord. The meninges we've been introduced to in the spinal cord, because these meninges actually envelop both the spinal cord and the brain, but here they are again for you, and I'm going to add a little bit to this. We understand that these connective tissue membranes are incredibly protective, and they each have their own unique function. Other than just providing protection, they also provide the framework and structure for the arteries and veins that are bringing nutrients and supplies to the brain. So protection is a huge part, but also these other functions. I am going to want to show you a picture that I think is a great picture that really shows these different membranes. The pia mater that is in contact with the brain is incredibly thin and a very fine kind of membranous structure. The arachnoid is sandwiched between the dura and the pia mater, and it's called that because you do see these little fibrous tentacles that almost are extending from that. So again, arachnoid means spider, doesn't it? We think of webs with spiders. So this is where the name comes from. This would be a great section for you to look at to try to really understand where these three distinct meninges, aka alias membranes, are actually located. And I do want to talk to you briefly about a condition that we know occurs sometimes called meningitis. Itis as a suffix, no matter what the word is, itis as a suffix means inflammation of. So in this case, inflammation of the meninges. This can be caused from many different etiologies. Etiology is the study of the cause, right? So it can be many different etiologies. When we try to look for good news, the good news is that most meningitis is caused from viruses. So you might be thinking, how could that be good news? Well, it's not always good news, but it's better news than if it were bacterial. And they don't even mention this in your book, but it can sometimes be fungal and even protozoal. So the cause is important to know. And the reason I say viral is good news is because viral meningitis has a much lower mortality rate, meaning that many fewer die from viral meningitis than do from bacterial meningitis, which is much deadlier. Fungal meningitis and protozoal meningitis, game over. I mean, essentially, those are horrific. But 5 to 1 causes, so, way more numbers of meningitis are caused from viruses than any other types of etiologies. So, when someone has meningitis, what are the signs and symptoms? Usually fever, a very stiff neck because of the pressure being put on the central nervous system, so they're not able to move. Definitely headaches, intense headaches. There can be neurological signs like drowsiness, not being able to respond, even going into coma can happen. But typically, with the high fever, the incredible pain of the headache, someone's going to go in and hopefully get a proper diagnosis. Now, if it's viral, the only real thing that can be done is treating the symptoms, making sure that the symptoms are being treated. And, it's not that it's going to be a walk in the park. It's not a walk in the park. And certainly we're going to treat all the symptoms of it and watch them carefully that nothing else develops from that. And depending on what virus it is, typically they're going to be a self-limiting type of infection. And most, not all, but most will get better and recover. As long as you're treating the signs and symptoms, and most will get better. Not all, but most. Bacterial meningitis is a whole different ballgame. So when someone is suspected of having meningitis, you must get to the etiology. You must find out, is this viral or is it bacterial? And heaven forbid it's not fungal or protozoal. But to get to the diagnosis, the definitive diagnosis, which means that you know exactly what's causing it, you have to do what's called a lumbar puncture. People refer to these as spinal taps. That spinal fluid, the cerebrospinal fluid, is going to be sent to hematology to do a cell count. There shouldn't be any cells in cerebrospinal fluid. It's going to be sent to chemistry to look at the glucose and protein quantities, and it's going to be sent to microbiology lab so that it can be analyzed to determine what might be causing this meningitis. Is it viral or is it bacterial? Now, what I want you to know about, and your textbook doesn't go into this, but I think it's important that you know, important enough that I'm actually going to give you I'm going to type these in and give you a slide on this. We know that bacterial is much less common, but you must know, because of treatment, how to treat it. You're going to have to do antimicrobials, antibiotics if it's bacterial, but also because some of them are incredibly contagious. So if a patient has come in with meningitis and it ends up being determined that it was bacterial, and it ends up being determined that it was a bacterial meningitis that was incredibly contagious, then it means all contacts that person came in touch with, even before they started showing symptoms, are going to have to take prophylactic antibiotics. Meaning, if it's a young person who's been in school and they were in close contact with some friends or teacher or maybe an ambulance driver or somebody in the ER, anybody that came in close enough contact with that person is going to have to take an antibiotic for a specified period of time to help to reduce the chance that that bacterium that they are going to have meningitis to. Not all bacterial meningitis are very contagious, but some are. Viral meningitis are not contagious. They're not. Protozoal meningitis are not contagious. Fungal meningitis are not contagious, but some bacterial are. So as a health professional, you're going to want to know if you came in contact with a patient that had something that is life-threatening. Because remember, the bacterial meningitis have a really high mortality rate. If they are not treated, it's tremendously high. So they must be treated. Okay, so I want to tell you about some of these microbes, and I'll let you know that the ones that I'm mentioning now, do not forget, let's see if I can type in the dark, are bacterial. These are from bacterial causes. The first one I want you to know is actually called Streptococcus pneumoniae. Now this is a species name, so it's in Latin, and whenever we name a bacterium, we always capitalize the genus name, and we always put the species name in lowercase. And the computer doesn't know the Latin spelling of the species, but that's how you spell it. Streptococcus pneumoniae. This is a bacteria. This is now the most common cause of all all ages, and the reason it is now is because for some of these we have immunizations for, and since the advent of these immunizations for some of these, we now are not watching all the time kids and young adults and people die of meningitis, bacterial meningitis. Immunizations, I got to see this in the 80s in the pediatric population, immunizations saving lives. In the 80s, we always had in our PICU, our pediatric intensive care units, and our neonatal intensive care units, we always had some child or baby dying in there of bacterial meningitis. But once immunizations started, especially in the early 80s, and for some of these, and continued on, now, thank goodness, we really don't have these as often. There is some concern now that people, because they think they know from their social media and their false claim sites that they're not getting immunized, we're going to start to, we'll see numbers go up, deaths go up again because of that. It's really unfortunate and it's a shame. So Streptococcus pneumoniae right now is still, Streptococcus pneumoniae is still right now. It wants to correct that, so I'm just going to leave it for now, but there's an E on the end of that. Streptococcus pneumoniae is one of the more common. But I want to tell you the one that's the most common in neonates, so newborns. In newborns, the one that is the most common is called Streptococcus agalactiae. This is the most common in neonates because this is actually called group B strep. And again, it's sometimes on lab reports, it's called GBS, group B strep. This microbe is in everyone's colon, large intestines. It's part of your normal flora. It's not causing you any harm. And some women, not all, but about 20–25% of women have this as part of their normal flora or normal microbes in their vaginas. So where do neonates move through to be born? Vaginas. That's birth canal. So neonates, if a mother is a carrier of this as part of her normal vaginal microbial flora, she is going to get an antibiotic prescribed and told that as soon as she thinks she goes into labor, to take an antibiotic. Taking one amoxicillin, penicillin, whatever gets prescribed. If you're allergic to that, you can't take those, but whatever gets prescribed, if you are a carrier of that, has reduced the number of meningitis of the newborn tremendously. So that prenatal practice of screening women, screening their vaginal areas, doing a quick test to see if they are carriers of this, which doesn't hurt them and doesn't hurt most babies coming through, but can cause meningitis of the newborn, screening them and then giving that antibiotic to them when they go into labor has drastically reduced the deaths of meningitis in a newborn. What a wonderful thing modern medicine is, right? So now the next one I want you to know is most often seen in young adults. should have done the other one first, but that's okay, I'll do this one. This one is Neisseria Neisseria meningitidis. This is what we sometimes call having to think about the spelling, meningococcal meningitis. Anyway, meningococcal meningitis. Now, this is the one that is so incredibly contagious. Neisseria meningitidis, if someone comes in contact with this, a patient who's had this, they're going to have to get prophylactic antibiotics. This one is so deadly that oftentimes, even with treatment, the person is likely to actually have devastating consequences like amputations of the appendages, serious consequences, or die. The mortality rate's really high on this. So, meningococcal meningitis. There's an immunization, though, for this now. It's called the meningococcal vaccine. So getting that vaccine has saved, again, so many lives. It's recommended to all kids at high school age to get this, and hopefully they are getting this. There is another Haemophilus influenzae. Again, these are Latin spellings. Haemophilus influenzae. This is actually sometimes, and it's the serotype B. So this is sometimes called Hib, Haemophilus influenza serotype B. There's a Hib vaccine. And so, again, the numbers of deaths that we've seen happening, these are usually toddler age children are the ones most susceptible to this. This bacteria can actually causes a lot of things. It causes middle ear infections, conjunctivitis, lining of the eye, the membranes of the eyes, what people call pink eye. And it can cause meningitis of young kids, but we've seen the numbers go down drastically. It also causes pneumonia, but we've seen the numbers go down drastically. The reason we've seen numbers go down drastically is that there is a Hib vaccine that's part of the pediatric protocol. Meningococcal vaccine that should be part of the pediatric protocol of young, middle-aged high school students. The streptococcal pneumonia, the pneumococcal vaccine, now that's all part of that immunization protocol. These have saved lives. So I want you all to know that meningitis can be caused from viruses. It can be caused from bacteria. It can be caused from fungi, and it can be caused from protozoa. And meningitis can be a life-threatening event. What is causing it is important to know so that you know how to treat. And sometimes knowing what your patient has can even protect you, because it might be one that you need to get antibiotics as a protection if you got exposure. Okay. So the next part of this is looking at the brain. We're going to see these ventricles and cerebrospinal fluid. We'll take a look at what cerebrospinal fluid is. So what you're seeing here is a lateral and an anterior view of the brain. So from the side and from the front. And you see they have superimposed what would be looking like these hollow regions. If we actually did a transverse dissection of the brain, separating the top from the bottom, and looked at this, it would almost look like there were these cavities in the brain, like these opening cavernous regions. But what this is actually, these are ventricles. And these ventricles, there is a right and a left one. Then there is a third, there are 4 ventricles, so there are the lateral ones, the right and the left. There's the third ventricle that is just sort of deep behind your nose, between your eyes, behind your nose. And then this 4th ventricle that's actually bathing this lower part of the brain, the brainstem and the cerebellum. So these ventricles are where cerebrospinal fluid is actually bathing the brain. I'd like this, there's a slide here, I thought it was sooner, but there's a slide here that actually shows you how the cerebrospinal fluid is moving and bathing the brain. So what I'd like you to know is that what the functions of it are, and there are important functions. The buoyancy means that it is actually, it sounds like it's floating your brain, but it is essentially floating your brain, protecting it. So, so you don't want the brain resting on any hard structures because, as it said, the nervous tissue would then end up dying. So it really is floating your brain. It protects in that respect. You know, we have all heard of shaken child syndrome and concussions that happen from the inside out. When a child is, or anyone for that matter, is severely moved in such a way that the brain would be hitting up against the inside. Like I said, a concussion from the inside rather than the outside. And that can actually lead to death. That we know. The chemical stability is really important. So rinsing away metabolic waste, but also keeping in regulation glucose and protein and other important substances. So again, this is just sort of a FYI letting you know that the ventricles are these regions where the CSF is actually moving through, and you can see some of the things I've highlighted for you here. It should be clear and colorless. Another thing, we produce about a half a liter, so 500 mLs is a half a liter a day. At any given time, you have approximately 100 to 160 milliliters, but anyway, that is moving through. The ependymal cells were the special glial cells that we said that we learned in our introduction to the nervous system are the glial cells that are actually producing and secreting the cerebrospinal fluid, and as it migrates and bathes the area, the arachnoid membrane, which was that middle meninge, the arachnoid mata has these areas where it's being reabsorbed. It's gathering it and reabsorbing it to the system. So you produce a certain amount every day, you're reabsorbing a certain amount every day, and that pace has to stay balanced. If the pace were not staying balanced, then there could put extra pressure on the brain. You don't want there to be too little, and then there also can't be too much. If there's too much, there's a term called hydrocephaly, water on the brain. Sometimes you can actually have what's called normal pressure hydrocephaly. It can be a little bit trickier to diagnose, but hydrocephaly, putting pressure on those neurons, again, can interrupt with the nervous system function. So this would never be considered a very good thing, and it would need to be addressed and treated as soon as possible. So when we think about blood supply to the brain, because so far we haven't really mentioned the blood supply and or the nutrients that are being brought, but actually the brain is, you can think of it as being a greedy organ. It's really necessary that it's got a high demand for ATP. So it really means that blood supply cannot be interrupted to the brain. Even a few seconds, showing here, I'm not going to ask you how many seconds, but even a few second interruption, this is why you can put pressure on these carotid arteries that are bringing blood to, and it doesn't take long for a person to lose consciousness. So that doesn't take very long at all. 1 to 2 minute interruption could have significant impairment, and then anything much over that, close to 4 minutes, means it's going to be irreversible damage and or leading to death. So the neurons have a really high demand for ATP. A constant blood supply is going to be vital. There is a blood-brain barrier that we know is provided by special glial cells called astrocytes. And this is sounds like a catch-22, that we have a blood-brain barrier, but we need a constant blood supply. The oxygen can move across really, really readily. So some of the nutrients can as well, but it is going to limit, it's going to make it sort of selectively permeable to what can actually come in. We don't want there to be an open highway between, like it essentially kind of is, between your blood and your tissues and your extremities and the organs of your visceral organs in your body, but not so much the brain, because it does need that protection. So we had talked about these astrocytes, these very special glial cells that provide that for us. And those endothelial cells, they can exclude harmful substances and only allowing the necessary ones to actually come in. Now, we also know that it's really permeable to water, glucose, and oxygen, even some things like gases like carbon dioxide, alcohol, caffeine, nicotine, anesthetics. So these are just, again, I'm not going to have specifics on that to know that it is selective in what it can allow in. A catch-22 is that it can be really difficult. It can be an obstacle for us to treat. So when something happens, like infections in the brain, meningitis, encephalitis means inflammation of the actual brain. Any of these types of situations, it can be very difficult to get the medications that we need across. Trauma and inflammation can damage it, and it can damage it permanently. If that ends up happening, then this is going to make a person so much more susceptible to having infections. So there is one area of the ventricles, it's between the third and the fourth ventricle, that blood does have a direct access to the brain. And the reason that you have this little Achilles heel area, this little sort of a weak area, and things can enter through here, but the reason is so that the central nervous system can monitor the different chemical properties of the blood. So it's monitoring pH, osmolarity, electrolyte function, so it's monitoring those areas. But essentially, that is a weakened area. So if you think about between that third and fourth ventricle that is directly behind the nose, and we do know that this is an access point for sometimes some viruses that have invaded these nasal mucosas. I always tell people you should be pretty careful what you put up your nose, because that is where we have that little weakened area where the central nervous system is monitoring everything else. All right. So the medulla and the pons here, these are part of the brain stem, and mostly the only thing, there are a lot of slides showing you different aspects of these areas, and you can see what's been highlighted here for you. But mostly what I want you to know about this is that these are controlling respiration. They're controlling your cardiac function as well. So heart and respiration, we certainly are concerned about that, are we not? They control other things as well. As we say, consciousness and sensory functions. But anyway, lots of different pictures here. I had the midbrain is the section here, and if we did a cross-section of the midbrain, I had talked to you all in the introduction to the nervous system about the substantia nigra. So in looking at this midbrain, and this is an oblique section here, you can see the substantia nigra. This was the area that we said where dopamine actually prevents unwanted motor contractions. So this is the area of the brain where we know is not getting the dopamine that it needs, and we call that disease Parkinson's disease. So this is just a picture of it for you, just for you to look at. Now, as far as the reticular, I don't ask anything about the reticular formation, but we understand that as sensory information is coming in through the spinal cord and through some of the cranial nerves, that this information gets sent up and processed through the thalamus to the gateway of the cerebrum, which is the gateway of the cerebrum, but also through the cerebellum. So the cerebellum plays a role in that as well. And you can see some of the functions of this. So relaying the sensory information to all of these areas and making sure that this is processed and sent back and integrated, and how it's going to be responded to. Again, cardiovascular function, cardiac and even respiratory, all in pain. So sleep, consciousness, again, of the brain stem. This is why people can have injuries to the brain stem and be in an irreversible coma. Not just injuries, sometimes tumor formations are actually putting pressure on that area, and that can lead to that. The cerebellum. The cerebellum is this area that we have already mentioned is the smaller part. The cerebrum, the lobes, make up the largest part. But the cerebellum is smaller, but has as many as half or more of the neurons that are associated with the brain. And we truly are, when we look at the brain, the cerebellum's highlighted here for you, we truly are learning more and more about the cerebellum and its functions every day. So not only do we know, we've known for a long time that it controls motor coordination and equilibrium type of activity, but now recently we're understanding that it's so much more. It's sensory, linguistics, emotion, so many other functions are depending on the cerebellum. So look at all of these things, comparing textures, perceiving space, recognizing objects, even a part of judgment and that type of thing, planning, scheduling, emotional control. So we're thinking it's really playing a lot with all of the functions that we associate it with our lobes of the brain. But look at this, many hyperactive children and children that are sometimes on the far end, the severe far end of the autism spectrum, they have smaller cerebellums. And we note that from scans, that they have abnormally small cerebellums, not always at birth, but during the development and after some of the signs and symptoms associated with some disorders like hyperactivity and like autism. There actually is a anatomical basis for that, and looking at the cerebellum, there's a difference in that. So if I skip through, you all know that you aren't going to be held responsible for this. I am going to have you label the thalamus, know that it is the gateway to those lobes, the cerebral lobes of the brain, and you can see that. So as information is processing in, moving up through the fibers, it's actually going through this gateway and being sent to where it needs to be. And I had talked to you also about the hypothalamus, and just that the hypothalamus is actually truly, when you think about it, is playing just the most essential role in regulating so many things in the body, and it does that through hormone secretions by regulating the pituitary, and then also having some functions all on its own, like the autonomic effects of blood pressure, GI secretions, so many different things. The hypothalamus is responsible for regulating your temperatures, whether you're hungry, whether you are thirsty, whether you are full, feeling full, sensations of full, sleep, circadian rhythms, memory, so many different things. So that is the hypothalamus. The epithalamus includes this pineal, and I'm just going to ask for the pineal gland here, and I told you that this has to do with serotonin release by day, that changes to melatonin by evening, and then that melatonin making you feel like you want to rest. This is stimulated by light, daylight. As human beings, we are animals. We should be watching the sun come up every morning. We should be exposed to enough sunlight, X number of amounts of sunlight a day, and we should be sleeping when the sun goes down. We can't see at night. The only way we can see at night is if we have artificial light. So humans haven't always had artificial light. We haven't always had even fire, or that's not really artificial because lightning can cause fires, but we can't see at night. So at night we would either step off a cliff because we didn't see it coming, or run into a tree, or get eaten by predators. because they can see us. Some of them can see us at night, but we can't see them, to run away from them. We're supposed to be somewhere safe at night sleeping, because sleeping is required for health. So anyway, but we've completely changed that, and we've changed it in a very short period of time in our human evolution, now with electric lights, not just fire and oil lamps and whatever, but now we've gone to electricity, and so people are staying up at night and changing this circadian rhythm, which changes our serotonin and melatonin 24-hour cycle. So what we're seeing are epidemic numbers of people who are in states of clinical or chemical depression, meaning they're not getting enough serotonin. It's not being produced in the right amounts. It's affecting their sleep, and so then their sleep affects their immune system, and then it affects every other organ system. Honestly, we're supposed to watch the sun come up every day and work enough outside, staying active and mobile, and then sleeping at night. And that means when the sun goes down, not at midnight. But of course, we have people who work night shifts now because of the activity that we depend on. We have people working around the clocks, that we are dependent on their services that do that. And it's just completely changed. So we have to make an effort for understanding that and maybe trying to change that a little bit or compensate for it by using phototherapy. People who work night should definitely be using phototherapy, using lights that provide that for them at night, and then during the day when they have to sleep, using dark out curtains, getting rid of that light so that they can artificially really try to recreate what the pineal gland is doing as far as serotonin and melatonin secretions. So those circadian rhythms are important to maintain. The cerebrum, I had talked about the hemispheres, so I've kind of already talked about the corpus callosum, connecting the hemispheres, and I've talked to you about the functions of these hemispheres. It would be very important that you could match the functions to these lobes that are contained in the cerebrum of these hemispheres. So the frontal lobe being essentially personality, planning, how you're going to act on your memories, how you're going to act, voluntary motor functions. Parietal being sensory. Occipital, vision. Temporal is going to be smell, memory, learning, and emotion. I don't ask about the insula, but we may start using that later. So the limbic system, I am going to want you to know the limbic system is predominantly found in this temporal region. And the limbic system is composed of two major areas, and I am going to ask about the hippocampus, and I will also ask you about the amygdala, which are both part of the limbic system. The hippocampus is what we associate with memory in the temporal lobe. The amygdala is what we associate with emotions. An interesting little side note for you when you see the medial aspect of the temporal lobe here, and this is the amygdala. A little side note here for you is that the amygdala in human beings is not mature until around the mid-20s age span. That's an interesting thing for me to think about, and for you all to think about, because when you think about your mid-20s, many people have already made pretty important decisions by then, and they had actions that may or may not have been wise choices by their mid-20s. But the amygdala, the emotional maturity centers, are not mature until around the mid-20s. So you think about all the things that maybe teenagers do, or very, very young adults do, that you may or may not have thought of as being a very wise choice. And can we blame it on the amygdala formation? Potentially. but maybe we should really understand it so that we can maybe help guide young people. Human beings, Homo sapiens as a species in the animal kingdom, has one of the longest stages of development where adults take care of the young. It's a very long stage of development, and that includes, this amygdala not being mature until then. So the hippocampus, memories, and the amygdala, emotions. How you're going to act on those emotions, you're going to use this prefrontal cortex, the frontal area of planning and judgment and, making those decisions there. So when we think about gratification and aversion, the sensations of pleasure and reward, or aversion meaning fear or sorrow, this is really how we learn. So this is actually just the way and how we learn. Now, the next slide I want you to know about is showing us someone who is having an EEG. EEG, and EEG stands for, and you would want to know, electroencephalogram. Electroencephalograms are actually measuring brainwave activities, and as you can see, there are 4 distinct types of brainwave activities that are measured by their how large the graph is, but also how close these peaks are together, peaks and troughs here. So these are 4 very distinct different patterns that actually happen. That's all I'm going to ask you. I'm not going to ask you to be able to recognize, which is which, but I do want you to know that this is how a neurologist would evaluate these wavelengths and know what is actually happening. So it really is useful to neurologists who are studying this to look at what is going on during these particular patterns and making sure that it is appropriate to what should be going on. So the alpha waves, awake and resting, beta waves, again, I'm not going to ask you these, but I just want you to know there are distinct patterns that we associate with this. Theta waves are going to be drowsy or sleeping, and delta waves are during deep sleep in adults. When we think of sleep, it is vital for your state of health to get enough sleep. Every individual has a known amount, depending on their, what's going on in their life, a known amount of sleep that they are going to need. Some people really need less sleep than other people to stay in a perfect state of health and well-being. Genetics plays a role to this. Overall health plays a role in this, how much sleep you're actually needing. But we know from sleep studies and more is being discovered all the time now about sleep. We know what kind of pattern we would like to get to. And if you look at this second chart, not the top one, but this bottom chart, this is the pattern that if they're showing this to you on a typical 8-hour sleep period. But if you could get this pattern in 4 hours, that would be all you would need. But there are some people who would need 10 hours to get this pattern. There are some people who would need 12, believe it or not. It's whatever your body needs to get into this type of pattern. And this is uninterrupted sleep. So what they have done is taken one of these sections and blown it up so you can sort of see the different wavelengths that are happening during this pattern. I want to bring your attention to these bars that look kind of yellow here called REM. This is referring to rapid eye movement sleep. So in one of these slides, they're talking about rapid eye movement. But what you would want to see here is during rapid eye movement, your EEG actually looks a lot like you're awake and active. All of your vital signs have increased. It looks like you're very active. You're essentially paralyzed during this. You've got a sleep paralysis going on. But if you notice in this pattern that's considered a restorative sleep cycle, REM, it took a long time at first to get to REM. It took almost 2 hours to get into REM. and it lasted a very short period of time. Then it took a little bit less, and it lasted longer, and then longer, longer, and longer. The thing that you want to know about this pattern of sleep is that you need enough REM events, and each one lasting a little bit longer than the one before it, before your brain has actually had restorative sleep. So if you get interrupted in sleep, you have to start this whole thing again. I wonder how many of you get enough sleep. So sleep has restorative effects, and if you do not get enough sleep over a long enough period of time, it actually can be fatal to you. The hypothalamus is producing these neurotransmitters that are acting as hormones called orexins that stimulate wakefulness. So people who levels are whose are really low, then they're going to have something called narcolepsy. So if they don't have enough orexin, then they're going to have what's called narcolepsy. Narcolepsy is meaning that you can fall asleep even during the day when you're supposed to be active. So falling asleep driving, falling asleep in meetings, falling asleep, in places where really it's not appropriate for you to be falling asleep. That's called narcolepsy, and it's due to low levels of this particular hormone called orexins. Now, again, for restorative sleep, you would like to see this type of pattern happening. We know that when we think about knowledge or how we process information and learning, this is referred to as cognition. So cognition is really perceiving, thought, reasoning, judgment, memory, and intuition, being able to intuitively think about something that it would make sort of sense to you, and learning. So when we think about this, it's pretty complex. We know that a lot of the cerebral cortex is actually involved in this, and we know this because of people that have problems with this and doing PET scans, positron emission tomography, and MRIs. We can see that there are lesions in these areas of the brain where that's not functioning. So agnosia is the inability to recognize objects. So if you have lesions in that temporal lobe, you may have problems. Remember, temporal is memory. You may have problems with recognizing objects. Prosopnia, agnosia, is going to be the inability to recognize faces. That's very, very rare. Agnosia is more common than being so specific here. And then the frontal lobe, whenever there is damage to the frontal lobe, whether it is due to dementia, some inherited forms of dementia, whether it is due to stroke, whatever it may be due to, then this is going to end up leading to personality disorders and sometimes socially inappropriate behaviors. So that is all related to frontal lobe problems. Now, memory. It's important for memory to learn new things, obviously, more than just memorizing, actually creating pathways. So we talked about that in our introduction as well. But it's also important that you can forget, because our brains are assimilating so much information all the time that if you are not able to eliminate trivial information, it can actually lead to learning disorders. So you may be thinking that it would be nice to have photographic memories where you can remember everything that you've ever seen or heard, but that's not really true. It actually can lead to learning disabilities. So all of these things are important to manage. Amnesia is the inability to actually recall something of past events, and it can be antegrade, which means that you can't store any new memory, so you have short-term memory loss. You might not remember if you brushed your teeth that morning, or if you had breakfast already, or if you already took a shower. So you can't recall any recent memories. And some is retrograde. So retrograde amnesia is going to be that you can't recall things from the past. So again, hippocampus, which is part of the limbic system, is controlling our memory, and the amygdala is emotions. So important for you to kind of know that, and how we act on them will be based on the prefrontal cortex, but emotion is associated with the amygdala. Sensation is when we think about sensations, we also think about usually the parietal lobes, and then we have special senses. So special senses are going to be things that we talk about in chapter 16. So we'll take a look at that in just a little bit. And we're going to look at vision, we'll look at hearing, we'll look at many of the other taste and smell as well in our final chapter of the nervous system. So we'll look more at those in those particular areas. The only other thing, some of these slides are just for your information you can look at. It's kind of fun to look at these graphs, and you can see on the sensory area, which is behind the central sulcus, the sensory of the parietal lobe, you can actually, there's an actual spots that we know are associated with feeling different areas of the body. And then there's the same for the motor, which is in the frontal lobe. And we know where those areas actually are located in that motor area of the frontal lobe. Dyskinesia, this is movements that are, it's a cause from lesions there, so these are unwanted types of movements that can happen. And ataxia is actually referring to more of a clumsy, kind of awkward gait. That's what that term is referring to. And you can actually see how this information is processed and moved up to the cerebrum, and then, you know, sensed and whatnot, and then moved back down for the motor control. Language. Language is including several types of abilities: reading, writing, speaking, understanding words. So it's really pretty comprehensive in our communication and what is needed for communication. And there are two major areas in the brain that we are associating with the ability to be able to communicate: the Wernicke's area and the Broca's area. So in this picture, you can see that the Broca's area is here in the frontal lobe. The Wernicke's area is here sort of at the back of the temporal and here in the parietal as well. And what I'd like you to know about these two areas is, depending on where damage happens, trauma or stroke or tumors or what it might be, damage has happened, we can figure out why the patient has lost what they have lost. The Wernicke's area is going to allow you to permit you to recognize spoken, written language, preparing the speech. And then the Broca's area is going to be the motor, because you know that's in the frontal motor functions, movement, motor meaning movement, the muscles of the larynx and the tongue and the cheeks and speaking. So aprosodia is going to be flat, emotional speech, emotionless, unemotional speech, and lesions here is what can cause that. So again, aphasia is actually a language deficit, and it can actually be because of the Broca or the Wernicke's. So non-fluent, meaning you're going to have slow speech, and it's going, that's what it's going to affect. Fluent from the Wernicke's aphasia means that the speech might sound normal, but it's usually senseless jargon because you haven't been able to plan it. There's no planning of it. So there's different types of aphasia depending whether it's the Broca's or the Wernicke's area. And speech pathologists and neurologists will work together to figure out plans of action if there's been damage in these areas to try to help these people communicate. And it would be very difficult, as you can imagine. Cerebral lateralization, I don't ask you anything about this because new evidence, new science is suggesting, and remember, science is sort of a mobile field. We're always learning things and having to accommodate that new information, aren't we? So, but they're really suggesting now that cerebral lateralization, right and left hemispheres, maybe aren't as defined as we have thought in the past. We do know that if somebody is right-handed, which about 90% of the population is right-handed, that they heavily rely on the left hemisphere, and vice versa for left-handed people. We have much thought in the past that there's certain things that are associated with that left hemisphere versus the right hemisphere, but we know that the brain is fairly plastic. And when I say that, I don't mean actually plastic like a polymer. I'm talking about there is this ability to change and be mobile. So we know that when the brain is injured as a very young person has brain injury, they're almost going to be, well, hopefully they have a much better chance of the brain that's still remaining functioning to take over any of the functions that the brain would have been at normally. So in other words, if there's injury to the brain, the younger you are, the more probability or possibility that the brain can handle that, and actually you can get the function back. Now, the older you are that brain injury occurs, the older you are, the less likely the brain is going to be able to accommodate. So if you've had injury and lost some sort of function that was in the right hemisphere, it's less likely that the other parts of the brain could take over and provide that. So and again, when I say plasticity, I mean just the ability to mold, the ability to take over. That's all I meant by that. All right. So I don't really talk too much about this now because there does seem to be new information that suggests that maybe that's not as much as we thought. The cranial nerves, the 12 pair of cranial nerves that are coming from the brain, they have been enumerated with Roman numerals. And these Roman numerals, as you can see, 1, 2, 3, 4, 5, as they go to 12, 1 to 12, they've been numbered by just as you would encounter them moving from an anterior, this is an inferior view of the brain, an inferior view of the brain. So if you took the human brain and looked at it from the bottom up, so they've been numbered by just as when you encounter them. This is the first one, olfactory, and then the optic is here, comes into play here. And so anyway, that's how they've been numbered. But I don't care that you know their numbers. Like I wouldn't care that you know the facial nerve is the 7th nerve, or even that the vagus nerve is the 10th nerve. I don't care that you know the numbers. But I wouldn't want you, if you heard the name of the cranial nerve, to know its basic function. And its name actually tells you, usually, what its function is. Let's see if that's the case, and make sure that you could match the function to the actual name of the cranial nerve. So olfactory means smell. Olfactory is referring to smell. So damage to the olfactory nerve would mean that you've lost the sense of smell. So as we recently are seeing with this pandemic and this coronavirus, this CV2, coronavirus 2, or CV19, because of 2019, is when this pandemic, was first recognized, this virus. This virus, we do know, had effects to the olfactory nerve. So people lost some sense of smell. And because smell is so directly tied to taste, people have lost the sense of smell and taste. So we do know that in some people, this nerve was affected. But okay, olfactory means smell. Optic means vision, to see. Not so hard, right? Oculomotor, motor means movement, as we've seen repeatedly, that means movement for your eyes. So helping to move the eyes. Now, if you can't do that, then it obviously could affect your vision. So that's really essentially all I want you to get from this part. The trochlear nerve is another one that is going to help with movement of your eyes so that you can focus. So again, vision, eye movement and vision. The trigeminal nerve is, if you see, it's coming from the pons here. Remember, you can see this area. The the medulla, the pons, the midbrain, the thalamus, just to give you an idea. So it's coming off and it's branching. This is got 3 major branches here to these different areas of the face. And mostly what I want you to know is sensory. So somebody kisses you on the cheek. If you feel the wind on your face, it's because your trigeminal nerve is functioning. It's functioning. The trigeminal nerve, sensory to the face. Abducens in its name, you all know abduction means to move. Is a specific type of movement, isn't it, away from the midline? But anyway, so this again is for eye movement. You'll notice there are quite a few cranial nerves that are all dealing with your sight. This is because sight is vital for survival. If we were not a social species and we didn't take care of someone who couldn't see, they wouldn't survive. They wouldn't survive. So, but we are a social species, and we're not the only animal social species. There's some other animal species that will sometimes take care of individuals that don't have have lost a particular sense. But anyway, sight is vital for survival as an individual. So there are quite a few cranial nerves that are related to the movement of your eyes so that you can actually have clear sight. The facial nerve, at first glance, looks a lot like that trigeminal nerve did, but the facial, because it looks like it's sending out many different, nerves to the different areas of the face, but mostly this one is for movement. So the facial nerve is going to be a major motor nerve, so expressions, and we know that most of our body communication is actually silent. It is from our body language. Communication isn't all just the spoken word, is it? So it does other things as well. So salivary glands, tear, those type of things, but I mostly want you to know right now that it is for movement. So damage is going to cause sagging facial muscles, and remember, you have a pair, so there's one going to the right, there's one going to the left, and so you have that, and if there's damage, then it's going to be almost paralysis of that area. So this is important to note. There's viruses sometimes that can attack these, and you all have probably heard of Bell's palsy. Bell's palsy can, and this is usually an immediate thing that can happen after. Typically we think it's after an infection that might not have even caused you to be sick, but your immune response caused this syndrome that we call Bell's palsy to happen, and it looks like someone has had a stroke. It can happen at any age, and it is temporary. It is typically temporary, will last a couple of weeks or a few weeks, or usually not too much more than that. On rare occasions, it will be a permanent type of paralysis, and it can happen to any age, babies, toddlers, to teenagers, to adults, to whatever. Also, you know that strokes can affect this area, and it can look like there's complete paralysis. So you rule out a stroke first if you ever see somebody, no matter what age they are. If it looks like they've got a sagging part, side to their face, you rule out a stroke first, obviously. So there are 5 branches of that facial nerve, and I bet you would recognize these terms. Cervical, meaning toward the neck, right? Mandibular, the lower jaw. Buccal is the buccinator muscle, is for chewing, isn't it? Zygomatic bone, or cheekbones, and temporal region. So these are the different areas of that facial nerve. Vestibulocochlear. Most of you have heard of cochlear implants, and you know that cochlear implants help you to hear. The vestibulocochlear nerve is a nerve that its origin is here in the inner ear. This vestibular region is referred to as the vestibular apparatus. It is for balance. And the cochlear, this looks like a snail, doesn't it? It's actually said to look like a snail. This cochlear region is for hearing. So this nerve we associate with balance and hearing. Good enough. Glossopharyngeal. Glosso is referring to your tongue. Pharyngeal is your throat. So tongue and throat here. So I want you to know that this is actually for swallowing. Our tongue is so much more than just for our taste sensations, so that's important. It is a muscle that manipulates our food, helps us to speak. It is also for swallowing, salivating, and even controlling blood pressure and respiration. If you note, this is actually coming, this nerve is coming from the medulla. And I had told you that the medulla and pons are for blood pressure, cardiovascular, and respiration. You're going to see that there are a couple of nerves that are innervating this tongue. And you can see this is just showing you know one of the pairs here. This is why no one should intentionally or voluntarily mutilate their tongue. This can be a life-threatening event. And that's just a fact. So anyway, there's no upside to that. So at all. I mean, I guess people think the upside is something to do with sexual, but it's mostly just saying that you need the sexual help. Okay, just scratch that. There's no upside to that. That can be damage to a tongue, can actually be a life-threatening event because of these cranial, and this is just one pair so far. This is the 9th pair, the glossopharyngeal. So making sure that we understand that. The vagus nerve, which is close to that glossopharyngeal nerve, I want you to look at the branches of the vagus nerve. It is innervating our heart, lungs, liver, stomach, all of the visceral organs. If both are cut or both are damaged, it's fatal. That's fatal. So this is the major roles in, let's see, all the vital organs. All your vital organs. Vagus nerve, paravagus nerves. The accessory nerve, this is a very superficial nerve to the sternocleidomastoid. You all had this in the trapezius. This is going to be head and neck, shoulder movement, swallowing as well though. So damages, typically when this is such a superficial nerve, typically if there's damage to this, there's going to be pulling to that side. And sometimes that is not correctable when that has happened, when there's been damage to the accessory nerve. The hypoglossal nerve, again, below the tongue, innervating this tongue. And if this is damaged, then you can't stick your tongue out. And typically it's going to interfere with speech, food manipulation, and swallowing. And humans, you might be interested to know this, humans are very much at risk for choking. We have this, our neck is a very small area with so many important structures moving through, carotid arteries, jugular arteries, our trachea, our larynx, you know, all these things that are so important here, the vagus nerve, so much going on here in the neck. So swallowing into the esophagus, this little small opening muscular tube, we're at risk for choking. So anything that can affect these cranial nerves that are responsible for helping us to swallow, manipulate food in such a way so that we swallow without danger is going to be important. And again, you can kind of look at some of these nerves and just being able to match major functions of what they're doing, and that was just the major functions. There are more functions with each, but they're the ones we want to get at this particular point. So there are a couple of disorders to talk about. Obviously, when you think about any injury to any of them, and knowing what their name was and what they did, then you could have lost that function. But there are a couple of others I want to talk about. One of them is called tic douloureux. This is trigeminal neuralgia. Neuralgia just means nerve pain. So that's a general term, an umbrella term that means nerve pain. But trigeminal neuralgia means that the trigeminal nerve, the one that, broke off to lots of areas of the face for sensory, so that you can feel when something touches your face or something's crawling in your eyebrows. Whatever. You can feel. This happens, and when this does happen, it causes intense pain. And when I say intense pain, patients will say that this is completely debilitating. The pain is so sharp and so unexpected, because it can just happen like that they will fall down and, be writhing in pain. It can happen. We really don't understand too much. It's probably an autoimmune response. And oftentimes it may never recur. So it may last for a little while and then not recur. And some patients who've had it, they have recurring episodes. Like they will be in remission for a long period of time, but then have recurring episodes of this. Some patients have had, it has been so debilitating for them that they've decided they don't want to sense. They would rather have it cut. They may cut the nerve to stop the pain. And if you can imagine giving up the feeling of someone kissing you on the cheek or feeling the wind in your face, that's what they've decided to do because the pain is so bad. So, and it can be triggered by most anything when it actually is occurring. Now, there is also, I told you about Bell's palsy. Bell's palsy, I don't have a slide on that, which is unusual. Bell's palsy is of the facial nerve. So that's why you have that paralysis when you have Bell's palsy happening. Leva, that's not in there. Okay, so that's just how we know these functions are occurring in these different areas of the brain, and how we know which particular area is actually engaged with which particular activity is through doing lots of studies with PET scans and MRIs and EEGs. So that shows you a couple of these in your textbook. So that is our introduction, or it is our introduction to the brain, looking at the brain, the different areas of the brain, and what their specific functions are, and then also looking at those 12 cranial nerves and what their specific functions are. So that's it for this topic.